Good evening and welcome everyone to tonight's webinar with Kids Matter on supporting children affected by trauma. So glad that all of you can join us this evening. I'd like to start by acknowledging the traditional custodians of the land and pay my respect to elders past, present and future, for they hold the memories, the traditions, the culture and hope of Aboriginal and Torres Strait Islander Australians. So I'd like to start by welcoming everybody to the webinar this evening. We have 411 people online from around Australia and some from overseas as well, including Hong Kong. We've got people joining us from Melbourne, Adelaide, Broken Hill, Dubbo, Cairns. It's great to see you all. Feel free to use the chat box to connect with each other and tell us where you're joining us from and what area that you work in. This webinar tonight is run by Kids Matter, and we welcome all of the Kids Matter health, early childhood and primary school participants that are joining us from around Australia. I'd like to start by introducing myself. My name is Amanda Harris and I'm the facilitator this evening. I'm a psychologist and also the director of the Australian Child and Adolescent Trauma, Loss and Grief Network. I've worked for over 15 years now with children and families affected by different experiences of trauma and adversity. And I'm really pleased to introduce everybody on the panel this evening who also bring with them a huge wealth of experience in the field of working with children who've been exposed to trauma. So tonight's panel really brings together a group of interdisciplinary experts. We have Dr. Penny Burns joining us. Penny is a general practitioner and also a senior lecturer at the University of Western Sydney. We have Michelle Roberts joining us from Victoria, who is a psychologist in the education sector and also has a wealth of experience in working with children affected by disasters. We have Janet Williams-Smith, who brings experience with her from the UK and Australia. She's currently the General Manager of Early Childhood Management Services and has a great deal of experience working with children from vulnerable families and developing programs for those children and families. And we have Rachel joining us. Rachel is a survivor of domestic violence and is known as a keynote speaker and an educator in the field of the impact of domestic violence on children and families. So it's great to have everybody here with us this evening. We're just going to go through some of the ground rules. I'm not going to read through all of these ground rules, but you can see that they're up there on your screen. One thing I would like to highlight is that we have the general chat box that's flashing through down the bottom of most people's screen, probably. And sometimes that can get a bit distracting and detract for some of the key messages that are coming through. So if you find that that's the case for you, please feel free to minimise it so you can turn your focus back to the webinar. Hopefully you've had a chance to look through some of the paperwork that's come out for the webinar tonight. Included with the case study, you will have seen that there's some learning outcomes from tonight's webinar. And this is really, as I said, an interdisciplinary panel discussion. So we can bring together this range of expertise from different areas. We really hope that by the end of tonight's webinar that you'll have a better understanding of how trauma presents to children of school age and in early childhood, have a better understanding of the impact that trauma has on children's social and emotional well-being, and be able to, both individually and through working collaboratively with other services, be better equipped to respond to the needs of children and families who've experienced trauma. So, this evening's webinar is going to consist of a presentation from, first of all, myself, and then we're going to go through the other panel members. We'll all give a unique perspective on tonight's case study from their particular discipline. After we've had a chance to hear from all of the panel members, we will have some time at the end for answering questions. So if you have, some people have already submitted some questions prior to the webinar, but if you have any questions that arise for you that you'd like to submit for us to answer towards the end, then please feel free to use the chat box at the bottom of the screen to do that. We won't have a chance to get to everybody's questions, but we're going to keep an eye on it and really hope that we're able to answer as many questions as possible. So I hope that you've all also had a chance to read through this evening's case study. So this evening's case study was a 2-page case study on Jack, Matilda and Jacinta, and some of the behaviours that they presented with within their early childhood and school settings. Jack, Matilda and Jacinta had all been affected by the domestic violence that they witnessed in their family home. And this was presenting differently for them in their different settings after their parents had separated. So hopefully you've had a chance to read through that case study because our presentation from our panel members will be really focusing on that case study. I'm going to start now with my presentation and then I'm going to hand over to Penny Burns. So at the beginning of this webinar, I really think that it's crucial when we start to talk about trauma that we acknowledge that the impact of hearing about the trauma of children and young people and working in the area has on us as professionals. So self-care is really vitally important. It's something to be aware of as we go through this webinar as well. We all carry with us our own experiences of maybe trauma or really difficult life circumstances, and sometimes these can come back to us when we're listening to stories of other people's trauma or we're learning about trauma. So please bear that in mind. If you need to take a break at any stage, then please do that. The webinar is going to be recorded and it will be available through the Kids Matter website following the completion of tonight's webinar. So I think by now, most people have a fairly good concept of what trauma is, but I'm just going to briefly touch on this. So really, trauma are experiences that overwhelm the child's capacity to cope. And there's 2 broad types of trauma. We say that there's a single incident trauma, which is also can be known as a type 1 trauma, or multiple or chronic trauma, which can also be known as type 2 trauma. Single incident traumas tend to be those one-off experiences where children are travelling along fairly well in life and then they experience something such as a house fire or a severe traffic accident or perhaps even a disaster. Your multiple or chronic traumas tend to be those that are repetitive, so they might be repeated exposure to difficulties within families such as abuse and neglect, domestic violence, or it could also be that there's been several occurrences of single incident trauma or adversity. Complex trauma are those traumas that occur repeatedly and are often cumulative, and often they also increase over time. This is where we start to talk more about those children who have been exposed to abuse, neglect and family violence. We also talk a bit about adversities, and adversities are those stressful life events that happen to nearly all of us at some time during our life, but that can be quite difficult for some children to cope with, particularly when they occur frequently or when there's multiple adversities present in a child's life. So that can be, adversities can be things like separation and divorce, having a parent with a mental health difficulty, having a parent with a substance abuse difficulty, having bullying can be an adversity that some children face, having a parent who has contact with the forensic or justice system as well. So in terms of what we see or what we know around Australian children's exposure to trauma and adversity, we know that at least 2/3 of Australian children are going to be faced with at least one experience of trauma or adversity, but by the age that they're 16. And that's come from a couple of longitudinal Australian studies, and we can see that that's fairly similar around most developed countries around the world. We also know that around 20% of kids are going to be exposed to multiple adversities. We talk about multiple adversities, particularly being 3 or more adversities, because we know that once kids start to face 3 or more adversities, and particularly those family adversities that they may be facing, they start to be overwhelmed and their ability to cope can be compromised. And we can see a greater impact across a number of different areas. When we think about Indigenous children and families, we know that they often experience much higher rates of adversity and trauma. And a study from Western Australia showed that around 70% of Indigenous children had exposure to multiple adversities. Within those traumatic, those experiences of the trauma and adversity, we'll also have a little bit of information around what the prevalence is for each one. And just to give you a few examples, we know that around 5 to 6% of Australian children will be exposed to a natural disaster each year, and that comes from a longitudinal study of Australian children. And we know that up to 23% of Australian children may also be exposed to domestic violence in their homes. Now, that's quite a tricky figure to estimate the prevalence on, because unfortunately there haven't been great studies in Australia that have really looked around the prevalence rates for children's exposure to domestic violence, and that's certainly one area that we hope to see more research on. So there's a number of impacts, and I'm just going to touch briefly on these because our panellists do talk about these in more detail later on. But there are a number of impacts that we see when children are affected by experiences of trauma and adversity. More generally, we see that children who are affected often have an increased perception of threat. So they become more sensitized to threat in their environment, or they see it, they have a broader awareness of a potential for threat in their environment. So this may be through relationships, through their contact with other adults in their lives, or through their relationships with their peers. Trauma also has a significant effect on children's emotional health. There's been lots of studies that have shown us that trauma in childhood is very closely linked to the development of depression and anxiety, as well as other traumatic stress disorders, not only in childhood but through into adolescence. We also see that often children who are affected by adversity and trauma have difficulties in regulating their emotions, and that can be because of their overwhelming levels of stress that they have experienced, or because they've missed out on the skill development of some of those in areas of emotional regulation. So we may see children who become dysregulated and either become hyperactive, or who may become withdrawn as well. In terms of behavioural health, we often see kids presenting, especially in education settings, in preschools and in schools, with dysregulated behaviours. They have less skills in place to control their own behaviour and to manage their own behaviours in the classroom and in the playground. And that can lead to difficulties presenting within the classroom that impact on learning, but also leads to a lot of difficulties that in the playground that impact on their peer relationships. So that moves on to social relationships. They have difficulties often feeling safe and secure, and difficulties often reading the social cues of others. As I said, touched on, learning is often impacted, and I know that Michelle is going to cover that a little bit more in her presentation as well. So just to touch on some of the research, unfortunately this isn't really available in Australia at the moment, but we can look to a US study that looked at the presence of experiences of trauma and adversity in the lives of primary school children, and then looked at the impact that that had on a number of different domains while they were at school. So there were just over 2,000 children who were randomly selected from 10 primary schools across the US, and teachers reported on the incidence of trauma, their exposure to trauma and adversity. There were 11 different experiences of trauma and adversity that they reported on. Children who presented with 3 or more of those adverse or traumatic experiences were 3 times more likely to have academic failure, 5 times more likely to have severe attendance problems, 6 times more likely to have severe school behaviour concerns, and 4 times more likely to have frequently reported health. So you can see from that study that it is having exposure to trauma and adversity is particularly relevant for children in early childhood settings and schools, and it's impacting children across a number of domains. And it was this study that really was part of the impetus to implement what they're called trauma-sensitive schools programs in the United States. So just a few things to keep in mind as we go through this evening's webinar. First of all, not all children who experience a traumatic or potentially traumatic event will be traumatized and develop difficulties. We need to think about each child and what they're presenting with. We can't assume that because a child has had one experience that they will be traumatized. Trauma all arises from an experience that's overwhelming or overwhelms our ability to cope. And there's risk and protective factors for every child. Finally, I'd just like to say that trauma is in the eyes of the beholder or the person who experiences it. So we need to think very much from the child's perspective. We can't assume on behalf of a child that one experience may be traumatic for them and another isn't. So just before we move ahead, it might be useful for you to keep in mind as we go along a child or a family that you've been working with who might be affected by trauma and adversity. Sometimes that can be helpful to come back to that child or family and think about the learnings from each panel member and how that might be applied to the child or family that you have in mind. I'm going to finish up now, and I'm going to pass on to Penny Burns. I'd just like to say before I do that, we're going to mention probably quite a few resources along the way in this webinar, and there will be a resources list that's made available. The web link will be pasted in the chat box at the bottom of the page. So those resources will be made available to everybody following the completion of the webinar. Okay, over to you, Penny.
Thank you, Amanda. So following on from what Amanda said, this graph here actually talks about that ACEs study and looks at the effect that adverse childhood experiences can have not only on poor mental health but on physical health outcomes as well. And we know that there's a relationship between exposure to abuse during childhood and risk factors for several leading causes of death in adults, and that includes cancer, chronic lung disease and chronic heart disease. So early identification is really important in this situation. One of the advantages, I guess, of having a general practitioner is that there is that existing relationship for the child and the family, and that mutual understanding that already exists either before, during or after adverse events that occur. And so it's really important that the child is considered in over mental and physical health in a sort of a comprehensive way, so that their strengths, their activities, their medical history, their daily living is all taken into account as well, and with the trauma just being one part of that. And it's very important that if we can keep that continuity of care going on through into adulthood and through families and through communities, then there's that extra sort of ability to identify strengths and work with the child in that way as well. And one of the opportunities in general practice is that we do have time to spend time with the child. We get to know them. I have children, they come running into the room, they go to the same drawer each time, they pull out the toys that they know that are in there. And I see their behaviour every time they come in. And so it's an opportunity then, if there's a change in behaviour, there's a change in the way the child's interacting with me, then there's some early identification signs that can occur there. The other important thing is to approach the issue for Jack with Jack. So it takes time to develop a relationship with Jack, and because hopefully the GP already has that relationship, it's already started. And what's really important is actually be able to sit and listen. And sometimes just sitting and listening is all you end up doing in some of the consultations. And I've had adolescent children where I've just sat and listened, or we've just interacted about what they're interested in for several sessions before we actually get on to talking about what the issues might be. And it's also, as Amanda said, it's really important to look at the child's perspective on how big these problems are. So a child that may look at one situation and find that traumatising, and another child may look at the same situation and not find that an issue. So it's a very individual thing. Physical symptoms are actually a common way that children present, and I have had a number of adolescents recently who presented with abdominal issues. So they've presented with gastrointestinal dysfunction, they've had diarrhoea, they've had soiling, they've had difficulty eating. And it's very important that we consider what the meaning is behind that we check to make sure there's no physical issues, but we also don't start over-medicalising and sending them off to various specialists trying to work out what's wrong without keeping the whole picture of the child in mind. And young children in particular, so Jack's siblings, as soon as there is an effect on Jack that we're suspicious of, we would automatically be looking at his siblings and the rest of his family. And in young children, the centile chart you can see in the corner there shows, in the bottom one, it shows the child's weight tailing off. And that's a sign that we need to look for something physical or mental that's going on with that child. It's a very clear indicator that we need to be looking at what's happening for that child. And the response is, in general practice, one of the things that is really important is the fact that it's a continuity of care, and it's within the family and the community, and it's involving Jack. So it would be a matter of working with Jack and his family to give them options and practical tasks and things to do. It'd be a matter of looking at collaborating with the school and probably collaborating with other health professionals as well, with Jack's permission and with Jack's mum's permission. It's really important, again, that we don't start sending off to different people without considering where the gaps in care are and what's important. Safety is paramount. In this situation, the incident has sort of been dissipated, but in other situations, ongoing safety is really important, and that may need to be considered. One of the benefits of general practice is that GPs can bulk bill, and I've had patients where I've had them come in with serious issues, and I've seen them day after day after day in consultation just till they actually started to be able to focus and think about what they wanted to do. So almost like having them in a holding pattern until they're able to decide what issues are important for them. And then I can see them once a week until they're starting to improve. The financial considerations can be considerable for people in these situations, and so bulk billing is one use. There's also ATAPs is available, there's GP mental health plans, and there's also GP management plans, but just simple consultations are often one of the easiest things to do. The other thing to note is that the record keeping is really important in these situations, because I've been called a number of times to talk about these issues, and the best thing for the child is if you've got really clear documented notes. So I guess in summary, I think the most important thing, the most important message I'd like to give you is that this is just one part of a child's experience of life. There's lots of other wonderful positive things going on, and it's also one moment in time, but it's a moment in time when you can actually hopefully make a difference, but it needs to be part of an ongoing comprehensive plan. Thanks, Amanda.
Thanks so much, Penny. That was a great perspective. I'm going to hand over to Michelle now. So just a reminder, Michelle's a psychologist and she works in school settings in Victoria.
Thanks, Amanda. So my focus is pretty much going to be, as a school psychologist, you've already spoken a little bit about how we understand trauma in terms of overwhelming events, that there's a subjective perception involved in whether we decide something is traumatic for us or not, and that two people can experience a similar thing and have a different take on it. I think it's useful to keep in mind that we have children in our classrooms who may be experiencing ongoing chronic types of traumas, and then there might be an overlay of a disaster, a flood, a fire, what we would call an acute trauma in addition to that. So it's important to start thinking of the child from the child's experience. I think the other thing that comes to my mind when I look at understanding trauma is that some statistics I saw recently was that 1 in 4 women are likely to experience familial violence. And if you think about education as such a female-dominated area, there's every chance that we'll have a teacher with trauma exposures related to violence within the home teaching children who have similar experiences without anyone actually knowing what's going on. We also spoke earlier about the biopsychosocial model, and when I think about how I conceptualise children when they're referred to me or their teachers want to speak with me about how they support with them in school, in my mind I go through each of those areas and I think about the child that's before me and where the impacts appear to be. In the last decade or so, we've had an explosion of knowledge around neurological impacts of trauma exposures. And as a school psychologist, it's important for me to think about what the adverse implications of those changes might be for the child's capacity to learn and to develop relationships with peers and adults in their life. So what we sometimes see is that a child was on a trajectory of a healthy, normal type of development and learning experience with strong attachments, and then something comes along to derail that. For children in a familial violence situation, sometimes those strong attachments have been fairly dodgy right from the beginning. But when I speak with children who have adverse exposures, traumatic events in their life, they're very able to articulate that their life was going one way and suddenly it went another way. I think as educators and school psychologists, the important thing for us is to know that we can make a difference and that we can assist in the repair quite often of those experiences and help kids maybe not to get onto that track that they were on before, but to get onto a healthy developmental trajectory and back on some sort of track. So Jack was the child in the case study that caught my attention initially, probably because he's school-aged and that's my area. He's having nightmares and flashbacks, intrusive imagery, he daydreams, he's fearful, he's pretty tired. And I suppose when a child gets referred to someone like me, a school psychologist, it's because the teachers pick up that they're not learning as they used to, they're not learning as well as the teachers would like, that they seem disengaged. They're often referred because of learning gaps or that they're failing to keep up with the learning and academic components of school. A concern for me is that often this is misdiagnosed, that teachers sometimes think that the children are lazy, that they're not wanting to learn, or that they have a learning disability without actually understanding the context for that learning problem. I suppose a lot of us have experienced children being identified as having attention deficit disorder because a lot of the symptomology is very similar to what we see in children with traumatic stress responses. And so we need to be thinking again of the child within their wider context, being brave enough to ask the right questions around what's going on in the child's life and looking at every aspect, the ecological model that surrounds the child and having a child focus in all of that. In relation to Jack, I wondered what it meant for his identity formation. Given that he's 10, he's probably starting to think about himself in terms of masculinity and having the exposures that he's had and having a dad that was there and then not there. We can also predict that there may be some difficulties for him in that area. I would hope that there's every potential he's got a strong attachment with a teacher at school that can help him to work through and understand what's going on and in some ways to provide some safety for him. Within the classroom, the consequences that we often see, that fatigue is a really important one. Waking up during the night in a roused state because you've had a nightmare about something that's threatening and feeling frightened around has a significant impact on capacity to pay attention the next day, concentrate, to encode new learning, to make linkages between new and old learning, to get on with peers and to have the sort of temperament that people want to develop social relationships with you around. We know that there's often impairments in short-term memory capacity and the ability to hold in mind information and to manipulate it in the classroom. Sometimes when I do cognitive assessments, we see some impact on executive functioning skills from trauma exposures. And in the classroom, that's often something really annoys teachers because these are the kids that come to class without their pens, without their books, not knowing what they need for what subject and so on. Often teachers just get pretty cross with them without understanding the context, as I said. In my mind, I've been starting to think about children with traumatic exposures in terms of regulation and dysregulation. We think in terms of autism and other neurodevelopmental disorders. In this context, we see the child that struggles to regulate themselves within the learning environment and in their relationships with others. We know, as Amanda said in the introduction, that neural pathways are often primed for threat when there's exposures to these sorts of adversities, and there's a limited tolerance to distress and capacity to self-regulate. If you think in terms of this being perhaps the teacher's experience as well, you can see a lot of capacity for sparking off each other in a negative way. Many of you will be familiar with the work of Siegel, and Siegel in The Developing Mind talks about the window of optimal learning, and that's where everything's in the right place for children to grow, develop, learn, encode the new knowledge. For children who've got trauma exposures, they're frequently hyper-aroused, so they're in that fight-flight mode where they're hypervigilant and finding it very difficult to pay attention to what's going on around them in a normative way. Or you have the children who are in that freeze-type mode, who seem to be dissociated, who daydream, who aren't really active participants in their life. Our goal when we know that children have these experiences, I guess, is to find ways to move them back into that window of optimal learning, or as it's also known, the window of tolerance. Little Matilda's only 4, but already we're seeing some of the consequences of the changes that have been occurring in her life. We're seeing signs of regression with her. We're seeing attempts by her to self-soothe, but we're also seeing evidence of that same dysregulation. Her repetitive play and attempts at mastery of what's a very difficult situation and to restore control to her understanding of the world, and her constant searching for nurturing come through in the case study. I was immediately reminded, I guess, of how important attachment with people is for children in their development, and in this circumstance it seems to me that she was receiving her attachment and stability from the educators at childcare. In Victoria, 4-year-olds are still at preschool, and I wondered what would happen to her when she had to leave the secure attachment that she had with her preschool educators to start a new life at a primary school and to hopefully restore some attachments, but how hard that would be potentially for her. And Jacinta, of course, is only 11 months old, and there's evidence that she's quite detached by her blank expression, and she's difficult to soothe. She seems to be quite vigilant, and she has difficulty managing change. And there'll be further conversation around Jacinta in the next presentation by Janet. So if I was to think about some of the things that we could do within the school context in terms of repair, I would be thinking about maintaining those positive relationships, providing predictability and routine, helping children to regulate and to be able to co-regulate, and reminding the adults in children's lives that children often take their cues from them. So a calm, nurturing classroom that doesn't have sudden surprises, loud noises and angry teachers is really important. There are different ways to teach that help children who have got trauma exposures, and one of the things that I think is really important is to use multimodality teaching, where you've got a lot of visual cues and charts to support the understanding. And of course then there's psychological first aid, which applies in the disaster context as much as it does in our everyday involvement with children with these sorts of exposures. Psychological first aid is almost so simple that people disregard it, but it's very helpful in helping children manage their exposures and their environments and creates a sense of attachment and predictability that might be missing in other parts of their lives. So psychological first aid is about providing a sense of safety, calming, so your self-regulation and co-regulation, providing children with a sense of agency and self-efficacy, reminding them of their ability to manage strong emotions and teaching them ways to do that would be an example of that. Facilitating connectedness and making sure that they are strongly supported by their school community and their peers, and making sure that you facilitate those relationships in the playground as well, and always having hope that getting back onto the trajectory that they were on, the pathway they were on before, is possible, or a new one, a bigger and better one. Thank you.
Thanks very much, Michelle, for that perspective. I'm going to hand over now to Janet.
Hello everyone, thank you for the opportunity to talk to you. So my experience is mainly with very young children, so children under 5 years old, in the context of kindergartens, early learning and care services, playgroups and in family therapy. That's sort of history as background in family therapy. So I won't be able to say too much about Jacket's school, but I'd like to talk to you about the younger children. So one of the first things that I thought would be useful to talk about is that young children don't have a narrative for trauma. You know, they're not able to tell us that something terrible has happened, or even interpret that they might be feeling in a certain way because something's happened. So they're much more likely to show us than to tell us, and that's the first thing that I wanted to say. And most of the things that I'll be talking to you about in the next few minutes will be around strategies of recognising and understanding that, And I also would like to, endorse what's been said before about, with Penny, for example, talking about differential diagnosis, and Michelle talking about misinterpreting or misunderstanding some of the presentations that children might make to us. For example, being diagnosed with ADHD or being diagnosed with, challenging behaviours, or, often in my experience of working in early childhood settings, children are seen to be naughty or difficult or struggling rather than actually feeling challenged themselves. So I think it's quite important to hold that in mind. So the first thing I'd like to show you is I use this in early childhood services to talk to educators and teams of people around really trying to plot children that they might be working with on this kind of framework that this is Bruce Perry's work. So it's really looking at what kinds of things might be happening to children when they're in different internal states, what parts of their brains are being used, and what some of their presentations or states of arousal might be when they're in those states. So I'd just like to walk through this with you, if you can see. So when children are calm, their cognitive state is abstract, so they're in probably the best place for learning and the best place to be. And I'm sure we've all seen children, and I'd like to reiterate, I'm talking about very little children from my own experience. They're completely lost in their play. They're completely lost in their world, doing what they're doing, and they're abstract. And the part of their brain region that's being used is their cortex, and they're restful. They're curious, and they're open to learning, and they're open to what's happening around them. And then the next state is a state of arousal where children are quite concrete and maybe aware of what's happening around them for some reason, and maybe a little bit concerned about what's happening, so they might be a bit vigilant. And if you look at some of the behaviours that were demonstrated by Jacinta in the very early days of her time in early education and care, she was very non-communicative as a baby, and she wasn't making eye contact. She was unsettled, and I would suggest that she was probably in a state between arousal and alarm. So moving on to alarm, the cognitive state there would be quite emotional and concerning, and children might become quite resistant. But in the same way, they might also become shut down and start becoming, moving into themselves. And that's really what Bruce Perry talks about. That's the time when children stop hearing. They can't really hear. They can't really understand what's happening to them. And that's the time that we need to really think about how we respond to these children. So, and then you move on to fear and terror. And, I very rarely, I don't think I've ever seen children in a state of terror. I've seen children in a state of fear. So one of the things that I found really useful when I've been working with educators and early childhood professionals is to work through this chart and say, maybe you could plot the children that you're concerned about on here, and maybe think about how they're feeling, what part of their brain is working, and what kind of behaviours or arousal states that they're presenting, and then start thinking about what our responses might be in an early childhood setting. So I think it might be useful to take that away if you're in an early childhood profession. And so the next thing I wanted to talk about was some of the consequences of that, and I've tried to divvy this up into impact and behaviours. So the impact of trauma on children, young children, I think that low self-esteem and very poor concentration, and I think Michelle talked a bit about that with Jack, and unable to self-regulate. So if you look at some of Matilda's presentations in the case study, she's not able to really be in a situation where she can start thinking about social play. I think there's a conversation in the case study about educators trying to get Matilda to use both her hands to stop her from sucking her thumb, when actually she's trying to regulate herself. So I think that trying to get her to do things that might be developmentally appropriate when she's in that state is probably not helpful. I think it's important to validate and accept that she's doing these things for a reason, and that she's doing them because they might be able to help her in some way regulate herself. And often children in trauma will demonstrate quite challenging behaviours, and I think that's there's an entry point of intervention in those challenging behaviours that starts in a different place. And it's not about controlling the behaviours, which is some of the things I've listed on the right-hand side there. I think it's around talking to the children about their feelings, which is the stuff I've talked about on the left-hand side. So, I recall working with a child in an early childhood service many years ago who was very, very distressed, and he just couldn't regulate himself. His heart rate was up, like seriously high. So we sat with him and talked to him about that, and talked to him about, your heart's going very fast, and I think it might be a good idea if we sit together and try and help you slow your heart down because it's going very quickly. And talk about what it's like to feel frightened and what happens to our body when we feel frightened, like our legs might feel like jelly, and it's important that we try and feel better. And responding to children like they're frightened and in trauma has a much, much faster and impactful impact on them than treating them like, trying to get them to respond to consequences. So I certainly think if you're experiencing challenging behaviours with some of the children that you're working with, try and approach them in a way that attends to their feelings. And I know that sounds like, not rocket science, but actually it can be quite difficult to do that. So some of the strategies that I thought, so the first thing I'd like to say is that much of the behaviours of traumatised children are pain-based. It's not that these children won't do the things that you want them to do, or it's not that these children won't respond, they can't. If you look at Jacinta, the only way that Jacinta started to respond to Nyomi, the educator in the case study, was once that she established a relationship with her. And that relationship was established through predictable routines, through a familiar person, through a secure attachment. And I think that what children need in those services is they need to know that they need one person. That doesn't mean that person looks after them all the time, but it means that person is the purposeful person that greets them in the morning and knows where they are and holds them in mind. So Nyomi, I believe, in the case study, had a really important impact on Jacinta because she connected with her and she made Jacinta realise that she was a consistent figure. And I think those things are really important. And I think it's important with children to acknowledge the feeling, not the behaviour. I think you might be feeling upset or frightened. And even with very little children, talking to them about that is very important. And relationships and attachments are critical. They're the only thing that's going to start the changes for those children when they're very small. And going back to what Penny was saying, I think one of the other things that's really important is the relationships with the family and also the networking that needs to happen around this family. So, I was very excited to hear that Penny was coming onto this webinar as a GP because the constructs around knowing that family for many years and the constructs around the community services that support those families is really important because the mother, Fiona, will need to know what the educator or what the service priorities are and what they're actually doing. So it's very important to use other service providers. I talked a bit about this. So purpose and intention is really important. So making sure the child has a structure to the day and knows what the pattern's going to be. I'm going to come in, I'm going to put my bag in the cubby, I'm going to have my breakfast. And don't underestimate the importance of that because children like to know what's going to happen next. And they like to know who their carers are going to be. And it's important to acknowledge that adults aren't unaffected by this. So one of the other things that's really important is to use your team members and work together. Because it can be very challenging dealing with children in trauma, and it can be very challenging for us personally, but also very challenging when you've got 25 children in a room and you've got 1 or 2 children that take up all your time. And I think that you need to work as a team and you need to make sure that you work together. And the other thing that I think helps, and we had a bit of a chat about this before, is that Matilda, if you look at Matilda's behaviour, Matilda is trying to control other children and tell them what to do because she feels out of control. She's also regressing because she feels frightened and little. So thumb sucking and pretending to be the baby and bossing everybody else around, I would suggest that she's trying to control the game, but also preserve a place for herself to be the baby because that's what she wants to be. And I think that kind of play is really important. She's demonstrating, going back to my first slide, she's showing us what she needs. And I think it's important not to try and get her to pick up the scissors or try and get her to do something else, because what she's doing is very important. So we need to let her do it, and we need to help her do it. I've just put this together, but just looking at feelings and behaviour. So, giving children choices and comfort and giving them control over things. So, for example, it would be really useful, I believe, in looking at Matilda's behaviour, to try and give her something really important to do, like, for example, feed the chickens or collect the eggs or go and help serve the morning tea. So she has a particular responsibility in the kindergarten that belongs to her, and she knows that that's hers, and she's in control of it, because that will respond to her feelings. So those things about choice, comfort, and control respond to feelings. Trying to get children to be compliant and looking at consequences is around behaviour. And I think that it's important that children are safe in their behaviours with other children, but it's really important that we hold on to their feelings and respond to their feelings, because their feelings changing will change their behaviour. Their behaviour changing won't change their feelings. So we need to deal with the feelings of the children. We need to give them a narrative. We need to give them words, and we need to give them choices about telling us. The tools that I found really useful in working with highly vulnerable children and children who are in trauma is, the first one is relationships. Relationships are critical. It's really hard to make changes in people's worlds if you're not in relationships with them. And I think, again, going back to what Penny was saying around the relationship that she has with that whole family and noticing the changes and being a consistent figure is important. But in an early childhood setting, relationships with children and educators, sometimes for children in trauma, the most significant safe, secure attachment for some periods of time in their life are their educators. And I think it's important that, you know, we also bear in mind that attachment is also about separation and loss. It's about change for children. And Michelle said something really critical, I think, about what would happen to Matilda when she goes to school. I think one of the things that's really important there is not to think about the transition to school, but the transition from where she's been. Because where she is probably going to feel safe to her. So it's important to look at what kinds of things have happened for her in that environment to make her safe that is passed on to the school. Empathy and transparency. I think it's important to be really transparent with the family and also the children about your concerns and worries, and also use each other to do that. Because sometimes it can be really difficult. It can be hard and having tricky conversations with parents about concerns about their children in your care. And again, I think you need to work together to do that. But it's very important to be transparent and be clear with Fiona about how her children are going and what kinds of things you're working on. Validation of fear and upset. You know, it's okay to say to children, I think you're really frightened and I think you're really scared, or, you know, I'm feeling worried about you. Remaining calm and taking time is really important, and being in control but not controlling. I think sometimes when children demonstrate behaviours that are challenging and difficult for other children to manage, it's easy to take control of it, rather than be in control and allow that child somewhere and some space to do that, but not be controlling. Okay, I think that's it for me.
Thanks so much for that, Janet. That was a great presentation. I'm going to hand over to Rachel now. Thanks, Rachel.
Hi, thank you. Okay, so there's so many important factors that everyone's touched on here, so I'm going to run through. The first one is in regards to roles and rewards. So obviously, with the removal of the perpetrator no longer in the home or family unit, Jack's going to feel that he has to step into his father's shoes, and that's going to have detrimental and positive effects. So him being only 10, he's still a child, but he may feel that he has to step up and be a bit of a male leader for the younger children in the home. So again, having him connected to counselling and maybe giving him some roles at school would be a more positive thing, and also encouraging some counselling sessions with him and his mother together so they can establish his role in the family as well as the younger siblings. So giving the children some areas in which they can participate at home, so with various chores to help mum, different tasks that might be starting them off and cleaning their rooms, you know, encouraging them doing reward if they put their toys away. So ensuring that, again, there's some sort of schedule and that they're still having family life as usual as possible amongst all the chaos. So obviously the demand and the stress on the mum's going to increase during this time. She might be looking for employment. There could be legal issues going on post-domestic violence and post-separation. So the children are going to probably feel the mother's increase in stress, and they're going to have to help her a little bit more, which is a good thing to give kids some chores, but also being mindful that they still have to then do their homework. So sometimes older kids might come to school and have found that, you know, they've had to help comfort mum. She might have been on the phone to a lawyer all night. You know, the perpetrator may have turned up at the house and had the police there again. So again, understanding, you know, why that kid's coming to school perhaps tired the next day is that there's other things going on at home that aren't usual for, you know, the normal family unit. Looking at the children's behaviours, again, in response to that, so offering reward and consequence. So they may not have seen consequences for the perpetrator in their family or home environment. So it's really important to have that chat with them and have that engagement and counselling with them and talk about that with them. If they are acting out at school or being a bully at school or trying to take control of situations and their behaviour is needing some consequence, talking to them about that and really finding out what the factor is behind their behaviour. So setting those boundaries at school while being sensitive to what's going on in their family unit And again, rewarding good behaviours and giving them some roles in the classroom and within the school, the daycare. And so the teachers also have got that role again, to influence positive friendships. So if they're on lunchroom duty or they're in the daycare room and they see some good kids that might be good for that child, to really encourage that positive friendship, perhaps suggesting that, one child goes and plays with another child and stimulating that and encouraging those good choices, and what's right and what's wrong, and having that discussion with kids. Was that a good choice? Was that the wrong choice to make, and why? So they can ascertain and identify that themselves and help manage that themselves. So the next slide. Again, some concerns to be aware of. So around this, safety is paramount when there's been trauma that involves violence. So there's a fear and anxiety, not just by the mother, but by the children as well. So some of the kids might actually suffer from separation anxiety. They might be wanting to be home with mum and be worried about mum and what she's experiencing during the day. Kids are exposed to that. The mum may have been on phone calls to DV services, to, the ex-partner. He could be stalking them. There could be threats by him trying to turn up and take the children if there's no parenting order in place. So again, understanding, is there a safety plan or domestic violence order in place? Has the mother come to the school or to the daycare environment and given them a copy of the domestic violence order? Are the children named on that order? What happens if the perpetrator turns up? So having those important discussions with the mother and also with the older children as well, just so that they know what's in place, and encouraging the mum to discuss that with them in case dad does turn up and says, hey Jack, come on, let's go, buddy, mum told me to pick you up. That may not be the case. There's also a fear from women who've gone through domestic violence about the Department of Child Safety intervention. It hasn't always been very positive. So there is a big fear around women reporting DV, of speaking to GPs. They're concerned that the GP, even though it's not mandatory reporting around adults, that it is for children. They're concerned that it might be reported to the Department of Child Safety and they'll be separated from the children. There's a big fear of a very biased legal system. We don't have a justice system, we have a legal system, and that repeatedly fails DV victims and gives access to perpetrators to their children where it's not safe. So there's a lot of legal issues for the mum that she's probably going through around, access by the perpetrator, family law courts, might be about property. There'll be financial and employment issues as well. So part of domestic violence understanding, it's physical, it's sexual, it's emotional, it's psychological, it's financial, it's spiritual. So there could be some issues there that the mother's experiencing, and that affects the kids. The kids might not be able to participate anymore in sports or, piano lessons because of financial issues, but also because the mother may have had to move into a new community. So again, the possible relocation from a family home, they might have had to move into refuge, they might have had to move into a small rental property, they might be staying with relatives. So again, the children's, their schedule is not consistent in that regard. Also looking at the perpetrator's connections to school and community. So there may have been someone that seemed or came across as someone very upstanding in the community. They may have even had a role within a daycare service or a school, or been a business who sponsored the school fete every year. So, actually looking at the safety issues around that and really connecting with the kids and the mum, and, avoid identifying information. So, if the mother and children have had to move, and if there's concerns about the perpetrator finding out where they live and they're in a refuge, then it might be best to use different names for the children. If they've received awards in the newsletter, to not publish them online, or give any identifying information where the children can be located. So looking at what have the children experienced and speaking with them about that. So what can seem normal to some kids and some families is actually not acceptable, and it's very unhealthy, it's not okay. And we know that, but they don't. So having those discussions with the kids, if they start to act out, if you see there's a lack of sleep, there's stress, some kids may end up being, displaying PTSD and OCD that's not even been diagnosed yet. Some kids may regress into behaviours, so toilet-trained kids may regress and start wetting again. It will affect their friendships and their schoolwork, so it's really important to keep the communication lines open with them. Also how they see themselves, their identity that was spoken about before, and the attitudes they're developing and their behaviours, so that early intervention's really, really vital. So where to now, what to do, how to support and engage with the mother and the kids. So victims often feel really isolated. There's a stigma and a shame around domestic family violence. So for them to really open up and speak about it is a really difficult position to be in. So you need to take care with your dialogue and terminology. You know, call it for what it is, if it's domestic violence, if it's a trauma, use the right dialogue. That can sometimes help victims to understand what they're going through and actually identify with it themselves. And just be really sensitive to the dialogue. If you're really not sure what to say, sometimes saying, look, I've never experienced this myself, but I understand how you feel and I really want to do something to help you. Let's look at how we can help. Sometimes that's just the best thing they need to do, is to feel validated and listened to and believed, and know that they've got support and someone's going to be there to help support them on that path, because it's a really difficult pathway to navigate. And when you've got children, in this case multiple children to look after at different age groups, you know, there's a lot of support and intervention that's needed. So don't make judgments. Don't, you know, say comments like, oh, what did you do? Did you make him angry, to the children or the mother? You know, just listen and support them. Tell them it's not their fault what's happened, you know, and it's a positive thing that they're seeking help and intervention. Do encourage them to seek help from other services. There's only so much you can do as an educator or as a doctor. And there's other services that are funded to deliver safety plans and get them to refuge and get them on a pathway to safety. So building trust is really important, just letting them know that you're there, you've got an open door policy. As Penny said before, note the disclosures. So that's important for GPs and for, say, school guidance officers, teachers. You've got your own policies in place at education at schools. So noting the disclosures, you may be called upon by the courts or even Department of Child Safety at some point for those notes. So making sure that you write those notes down as soon as you've seen that patient or that child, and that you're not biased in that you just write exactly what's been disclosed to you. So there's a lot of rebuilding the family unit that needs to happen now. So there's positive engagement for quality time. You know, the mum has to re-establish the mother-child relationships and also those sibling relationships that go together. So it's really imperative in order to do that to involve mum with decision-making planning, also Jack, the older child, and offer some choices to them. Obviously, as children, we don't give them multiple choices, but saying, look, you know, maybe to Jack, there's a leadership role here at school, you know, with the sports team, or, you know, would you like to help in the canteen on a Thursday? So give them two choices, something that might be of interest to him. You know, if there's a good sports teacher at school, maybe it's a male and they can connect with him and do some football, or, you know, really encourage him to join a footy team. So looking at those real good mentoring relationships. Again, so setting goals with the kids too is really important. So what would you like to accomplish in the next few months or this term or this year? And it might be, again, around a leadership role, more involvement with the school community. Knowing, and for educators, again, and GPs, there's a lot of different services out there. Sometimes it's hard for you to even navigate through them. So being aware of the government and community services pertinent to your area. So obviously there's Centrelink, and they can be, you know, very time consuming for people, but obviously they do have phone lines that people can ring in order to make appointments with social workers. There are free financial planners that work with Centrelink. There's also emergency payments when women have or victims have got a domestic violence order that might help them to you know, pay a week's rent or you know, to go into refuge. There's a Department of Housing regarding to public housing accommodation. There's lots of community housing organisations, legal aid, and some community counselling through like Selfcare and I think maybe Anglicare and places like that. Again, the GP response is important at this stage too. So looking at enhanced primary care plan, mental health plan, and bulk billing, and looking at the holistic treatment of the patient. So, you know, are there other mental health issues involved? Could there be eating disorders? What else is going on here? Where do we need to make the referrals to best support the mother and the children? And again, the school engagement. So for schools, a lot of times putting some great community-based organisations and sporting grants in your newsletter to communicate that home to families. Local sporting clubs like the PCYC, free library events. So when we talk about the rebuilding of that family unit, it's important to give the mother and the children in this instance some free pathways that they can go to do some activities together. And if they're new to the community, perhaps they've come to your school and they're new, again, engaging them in a safe space where they feel safe. So some practical tools. So the government, state governments usually print out what's called domestic violence safety cards. So you can keep these at the school office. you know, maybe a library. If you're in a doctor's surgery, have them in doctor's waiting rooms. If you know of a local community service or counselling service, or a drop-in or a play, mother's play group, and having those DV safety cards there where someone can pick them up confidentially, and perhaps you know, offering the phones at the school if they need to call a DV service, you know, somewhere that they can't be traced. There is obviously the National DV Hotline 1800 Respect, and you can refer to local services. There's obviously, you know, limited capacity for regional and rural services, but they still do exist. So just Googling domestic violence services or community services in your suburb, and also speaking to your local police or domestic violence, they're called domestic violence liaison officers at police stations. They're a good resource as well. So yeah, again, encourage a school to have an open door policy for families and for staff and students. So to come in and say, look, we're here if ever you need to talk. Encourage the medical practice or your school to link with a local domestic violence or community service, so you can build those connections and have some training, have them come in and the advocates come in and talk to your staff about what domestic and family violence is and the impacts on that, on families, including young children. Having regular meetings, again, with, say, DAC and the kids, with a chaplain or guidance officer or teacher with the parent and each child, so they feel involved in that decision-making process. Where to from here? How is Jack performing at school? Has he got NAPLAN coming up? You know, what's really important to him at this time? The teacher may say, look, you know, he doesn't have to hand in this project, but this other one's important. I can give him an extension. So really engaging with them around this time. So looking at their progress, reviewing those roles, you know, rewarding that positive behaviour. Using encouraging language to the children. So again, your dialogue is really important. You know, and asking how they think they're progressing. How do you think you're doing in maths? How do you feel that you're doing with your friendships at school? And, you know, encourage the use of a diary for older children and for mum, so they can write their feelings out if they're acting out or feeling that they can't express themselves verbally, to actually get them to write that down. And for schools, looking again at what are respectful relationships. So looking at online tools to explore with the kids what a healthy and unhealthy family relationship looks like. And it doesn't have to be identifying, it's just a discussion that you can have within your school community.
Thanks so much for that great presentation, Rachel. And, you know, it's been terrific to hear for such a wealth of experience that we have brought together on the panel this evening. I'm just going to touch on a few of the key questions that have come up this evening, and these have come from our participants both before and during the webinar tonight. Some of them we've attempted to answer in the chat box along the way, but there's a few key areas that have come up. So first of all, one of the really key areas that came up for lots of people, I'm going to address this to Michelle and Janet, was around how, what sort of strategies are good for managing children who might have been experienced to trauma and adversity and are displaying behaviours that might be difficult to manage in the classroom. Have you got any particular tips or strategies that you can share with the participants this evening? So I might start with you, Michelle, and then move on to Janet.
So I think I picked up on some of those things in my presentation, but as everyone's spoken, more and more information's come through around that. And I think our first struggle is to do the psychoeducation of the educators so that they actually understand what's going on for the child. And sometimes we don't know what the child's issues are, what the origin of the concerns are. So the trusting relationship where the parent that's with the child can talk with the teacher about that's also really important. There's some really lovely programs available for people to look at, such as the Make Space for Learning program through the Australian Childhood Foundation, that give educators a lot of really great ideas on how to teach children to self-regulate, to understand when that they're starting to feel so upset that they're going to lose control, and to help teachers to also be informed about their own self-regulation and how they can help co-regulate the child along the way. Amanda, you might be able to speak a little bit about the ARC framework and trust and some of the other whole-of-school strategies that can be implemented as well to be trauma-informed in the practices of the educators.
Yes, thanks, Michelle, and I'll mention those in, I mean, I just want to see, Janet, did you have anything to add to that?
Well,
for Michelle?
I'd like to endorse what Michelle's saying. I think one of the things that Michelle said that's really important is that we might not know the origin of the trauma, and we might not know the content of the trauma, and we don't necessarily need to know that. What we do know is what's in front of us. So going back to the first slide that I put up, which is that children aren't able to tell us sometimes what's happening, but their behaviour is very indicative of how they're feeling. So I would suggest that the strategy of trying to manage some of that behaviour is to actually deal with the feeling. And that means you might need some extra resources in the room for a while, because we need educators to build up relationships with children. And often, if children are demonstrating challenging behaviours, the feelings that we have around those children are quite difficult sometimes. So it's really important that educators address that with each other. They need to be able to get together and go, oh my God, you know, this child's driving me insane. And they need to be able to acknowledge that that's how they feel, because it might well be triggering things in them. But the strategies for me are around talking to those children and also playing with them. So going back to Matilda as an example, she's involved in this controlling game with her friends, and she's also involved in trying to self-soothe and also regress a little bit. I would suggest the best way to try and manage some of that is to get involved in the play as the educator and give her something to do that's really important for her. And I think the other thing is providing some boundaries for children. Children need to know that they are contained and that they are cared for, and sometimes that can be by physically having a cuddle with them, or some children even find it helpful to be like literally weighed down. I've known children that have had like sand blankets, things like that, but children who've asked for heavy packs because they want to walk around and they want to help themselves feel grounded. So there's lots of strategies, but I would suggest that the indicator of how to manage the behaviour is to talk to the child and respond to the way the child's feeling with a feeling response, not a behavioural intervention. Because children just can't respond to those consequences. When they're little, they certainly can't do that. And going back to Jacinta too, Jacinta was shut down. Lots and lots of predictable eye contact, facial contact, and lots of physical contact. Yeah.
Thanks so much for that, Jana. And as Michelle mentioned, there's with our network at the Australian Child and Adolescent Trauma Loss and Grief Network, we've been looking at an ARC framework as a whole of schools intervention for working with children who've experienced trauma, and that stands for attachment, self-regulation and competency. And they're really some of the three of the key themes that have come up this evening around developing relationships, being aware of our own responses, helping children to be able to identify where they're at emotionally and develop some strategies to manage that, and really promoting children's strengths and competencies and giving them those special roles in classrooms.
Yeah.
So we might just have time to touch on one more question. Rachel, I'm just wondering if you would like to speak about what were some of the most important things that you really needed from the health professionals around you, and the other people that you may have consulted along the way, including education professionals.
Sure. Look, I've got a lot of notes here, so I'll be really quick. For me, look, the first thing was non-judgment. So again, around that dialogue that I mentioned before, so not to be judged. You know, there's a shame, again, a stigma attached to domestic violence. So for me, it was to be believed and to be listened to. Bulk billing is imperative in domestic violence cases, or, you know, any sort of trauma where perhaps the mother will say, look, you know, I'm struggling financially at the moment. For doctors to then go and bill them is really difficult. A lot of referral to services for support. So again, knowing where to refer them to services. You know, again, I think too with early educators, you know, having a young child at the time is to not allow the perpetrator to come in when there's a domestic violence order in place. In my instance, they allowed a perpetrator to come into the early childhood centre because they said, actually, look, we were too afraid to say he couldn't come in, when they should have actually notified me and called the police. So again, knowing what the rules are and what the processes are to ensure the safety of the child and the mother around your centre or your school. Again, better recording the injuries and the impact of violence both on the child and myself. So a lot of GPs didn't make very good notations. So making sure that, again, as Penny said before, they might be called upon for court. You might need them for the Department of Child Safety. They might be needed, you know, for criminal charges for the DPP. So ensuring that those notes about the impact of the violence, both physically and mentally, are in you know, top-notch notes. You know, perhaps the acknowledgement and helping to understand what fight or flight response is for victims, and you know, putting that in I guess child applicable terms for the younger kids, but also to talk to the mum about that, and you know, to refer to other services like you know, counselling and using those enhanced primary care plans and mental health plans that, you know, are mostly bulk billed and free. You know, looking at the early intervention, as Penny said, the early intervention and prevention for further issues is vital, so that then you're not having to deal with, you know, you have early diagnosis of, say, mental health issues or other issues for the children and the mother, and so that they're not ending up later on having, you know, a permanent mental health, or, you know, referring them if they need to have x-rays done or MRI scans for head injuries, that kind of thing. You know, again, sort of, it's not mandatory for them to report if it's an adult, but obviously it is for children. But if they do have a victim of DV present, then for the GP to encourage them, say, look, I really would like to call the police or call a service to help you right now. Can we make the call? So while you're in the room, offering to call that service for them. They might not want the police involved at that point, but they may actually then choose to go down that pathway once they're engaged with the service and have a safety plan. You know, don't use medication as the first go-to. A lot of GPs are quick to go, let's just put you on antidepressants, because a lot of women, even as Rosie Batty has said, you know, a lot of women can seem, even in courts, you know, that they're, you know, quite flighty and very upset, that they're quite distressed. That is how they're going to present. That is how children can present too. So it's looking at what are we going to do here? What's the first response? It might be, you know, giving the patient some counselling and referring them on to somewhere else that's going to give them a sense of control. They feel that they've lost all control through the domestic violence situation or through the trauma, and they want to feel that they have some control. So helping them to learn how to self-case manage, you know, the negotiation of their medical pathway. If also you're a GP, I guess, so if saying that you're there to help, or if you're, you know, a teacher at the school or a guidance officer at the school or chaplain, you know, look, we're here to help you. I'm not here on Mondays and Tuesdays, but do you mind if I speak to my colleague who is, and they can also help you? So flagging it with another teacher or the principal or another GP to help that person, because we don't know when trauma and domestic violence is going to happen. It can happen at 2 o'clock in the morning or 3 o'clock in the afternoon. So we need to ensure that there's a consistency of care for that person. I could go on forever, but I'll be quiet now, Amanda.
Thanks so much, Rachel. That's a great response, and I think some really valuable information there for all of us, whether we work in education or in the health professions. So we're very quickly running out of time to close this webinar. But I think just quickly, you know, some of the key messages that we've heard tonight are that children are going to present differently, and they all have different experiences, but we really need to maintain our curiosity to think more about what's behind the behaviours that they're presenting with. And really helping any child or any family is about the relationship that we develop with that child and family. That's always the key thing that we need to focus on in order to be able to help kids with their emotions and the other impacts that arise from experiences of trauma and adversity. So the slides haven't come back up again yet, but there are some upcoming Kids Matter webinars that we'd encourage you to participate in the future. So there's one coming up on children with anxiety and another one on supporting mental health in infants. So please take the time to check those out and then register for those. We've been really heartened to see some of the great comments that have been coming up about how useful tonight's webinar has been. We've had over 500 participants this evening, so that's terrific. You'll find more about Kids Matter, and as I said, the links to the resources that were mentioned this evening will be sent out or will be available on the Kids Matter website following the webinar, in the days following the webinar. So thanks again for your participation this evening. When you go to log out, a exit survey will pop up. We really encourage you to complete that exit survey and share your views and opinions about how this evening's webinar went. So thank you to Penny, Michelle, Janet and Rachel for joining us for this evening's webinar, and we'll say good night from us.
Bye.